Hello, Dr. Stebbins. Hello, fellow future nurse practitioners. My name is Charma Dalope, and I'm going to present a case that I encountered for this week. So I'm going to begin with the patient's identifying data. NL is a 54-year-old African-American male adult who presented to the clinic alone and is a good historian. His chief complaint is, quote unquote, "I feel frequently sleepy and tired for the past 2 months. My wife is concerned of my loud snores." History of present illness. This is a 54-year-old male patient who presented to the clinic today with complaints of feeling fatigued for the past 2 months. He reports he sleeps okay, at least getting 6 to 7 hours of sleep, but still feels unsatisfied and experiences daytime sleepiness. He recalled snoring started during his early 40s. However, recently it has become progressively loud, and his wife verbalized that the snoring has become bothersome already. He was also told by his wife that she had to wake him up because she witnessed irregularities with his breathing. He admits his snoring began when he started gaining weight last year from unhealthy eating secondary to stress from work. He reports an episode of waking up in the middle of the night, feeling like he was choking. So the Epworth Sleepiness Scale is performed, to which the patient scored 20, which corresponds to high level of excessive daytime sleepiness. Upon physical assessment, he appears exhausted but not in any form of distress, with significantly large neck, measuring 43 centimeters. Tonsils are not enlarged, thyroid is not enlarged, no lympadenopathy, with normal breath sounds on bilateral lungs upon auscultation, and normal heart sounds S1 and S2. His past medical history include dyslipidemia and hypertension and is well controlled with medication. He has no medication, foods, seasonal, nor latex allergy. He does not have any surgical procedure done in the past and no previous hospitalization from illness. Going through his family history, his father is living and has a medical history of hypertension. Mother is living and has a medical history of type 2 diabetes. Paternal grandfather died at age 89 from old age. Paternal grandmother died at 77 and the cause of death is unknown. Maternal grandmother died at 59 from motor vehicular accident. Maternal grandfather died at 78 from COPD, and he has one brother who is living, also has a history of hypertension. With regards to his social history, he is married and lives with spouse. He does not smoke, drink alcohol, nor use illicit substance, and he works as a bank teller for 15 years now. He admits to not having regular exercise and unhealthy eating habits. His vital signs during the visit are blood pressure of 126/88, heart rate of 67, respiratory rate of 616, temperature of 97.8, oxygen saturation is at 98% at room air, height is 5 foot 5 inches, weight is 198 pounds, and a BMI of 33. So my differential diagnosis for this is obstructive sleep apnea, insomnia, depression, and hypothyroidism. With regards to my final diagnosis, based on the key findings from history and physical examination, final diagnosis will be obstructive sleep apnea. Sleep apnea, this is a condition where airway completely or partially collapses during sleep, causing decreased oxygen saturation, leading to episode of apnea or cessation of breathing. With regards to diagnostics, while the USPSTF does not endorse sleep apnea screening, the American Academy of Sleep Medicine recommends evaluation of adult patients about signs and symptoms of sleep apnea during health maintenance visit. The Epworth Sleepiness Scale is a questionnaire developed to determine the level of daytime sleepiness in adult individuals. A score of above 10 indicates excessive daytime sleepiness. In addition to history and physical examination, the gold standard in diagnosing sleep apnea is polysomnography. It is a type of sleep study that can be done in a sleep laboratory or at home that detects potential sleep-related breathing disorders. It measures the apnea-hypopnea index. Both must last a minimum of 10 seconds. It is calculated by adding all episodes of apneas and hypopneas and then dividing by total sleep time. An apnea-hypopnea index of 15 or more events per hour or 5 or more events per hour in the presence of symptoms such as fatigue, daytime sleepiness, loud snoring, waking up, choking or gasping, and cardiovascular comorbidities such as hypertension or stroke can be a diagnosis for obstructive sleep apnea. So going through the treatment, the continuous positive airway pressure is the first-line treatment for sleep apnea. It basically works by pumping pressurized air into a mask that is sealed around the nose or the mouth to keep the airway open. It increases the amount of oxygen in the lungs, allowing the patient to breathe and continue sleeping without waking up gasping for air. If the patient is not able to tolerate CPAP, oral appliance can be an alternative option. The American Academy of Sleep Medicine and the American Academy of Dental Sleep Medicine recommends prescription of oral appliance with a qualified dentist who will use a customized titratable appliance. Surgical intervention is an available option in correcting anatomic obstruction in patients with sleep apnea, which can improve quality of care. Examples of these are septoplasty, tongue reduction, and epiglottoplasty. With regards to education, obese patients should have weight regularly assessed and weight loss strategies incorporated into the treatment. The American Thoracic Society emphasized the importance of addressing weight management in reducing the severity of sleep apnea. From BMI of 25 and above, a comprehensive lifestyle intervention is recommended combined with reduced calorie diet and increased physical activity. For BMI 27 and above, consider anti-obesity pharmacotherapy if no cardiovascular contraindications. And for BMI over 35, bariatric surgery referral is an option if not contraindicated. Adherence to CPAP is essential to achieve getting sufficient sleep every night. It is also important to include education on proper hygiene and maintenance of CPAP machine to prevent contaminant from growing in the equipment. Follow-up, referral to sleep medicine to assist with treatment plan. After the initiation of CPAP, follow-up arrangement after 4 to 6 weeks is recommended for reassessment of symptoms and make adjustments if necessary. And for patients fitted with oral appliance, it is recommended that the clinician will order a follow-up sleep testing to evaluate the effectiveness of the device. And that ends my presentation. Hope you have a wonderful day. Thank you so much.